All right. Salam alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. So today we are going to cover, not this one. We're covering the orthopedic emergency. Orthopedic emergency. So we're going to cover a few topics very commonly tested. I really need you guys to give it your 100% focus, because if you focus in this lecture and listen to it until to the end, and I'm pretty sure that you will not get any question wrong. After this lecture, we are going to do at least 25 cases regarding or related to these topics that we are going to discuss. So if you pay attention to this lecture, you will not mess up on any cases that will come after this lecture. And I'm trying to point out the most commonly tested points of the topic. So we are not going to dive deep into details of any topics, but we are going to touch the most important points, which basically you guys are, mashallah, knowledgeable. So there's no doubt about your knowledge. I'm just pointing out the most important points. Okay. So learning objective by the end of this lecture, you should be able to answer MCQ1 questions. What is the best next step cases very safely. Not only that, what is the next step in terms of management, in terms of investigation, in terms of treatment, and so on and so forth. So recognize emergency. So when it comes to orthopedic emergency, so what are those clues that when we see that, we should say, oh, this is emergency. And why is it so important? Because if we delay, that will cost somebody life, or that will cost somebody a joint, or the patient might end up disabled for the rest of his or her life. So heart swollen joint, if you see it, that's emergency. Pain out of proportion, that is emergency. Back pain plus bladder red flags. When I say bladder red flags, if the patient has retention with back pain or incontinence or any other bladder issue or the abnormality, then that is considered an orthopedic emergency until proven otherwise. Open fracture contamination or contaminated, emergency. Limb ischemia after injury, if the patient has injury and then end up with having no pulse, different in terms of color, becoming pale, cold, in that case, or changes the color, then it is emergency. So based on these clues that now when we recognize that, oh, this is emergency, what should be our next step? So you should know that if you have a heart, painful, swollen, joints, the next step should be arthrocentesis. If you have a joint that is painful and the pain is out of proportion and it worsens with passive stretching, that is compartment syndrome until proven otherwise. So what should I do? The next best step should be to do a fasciotomy. Back pain with a bladder abnormality, whether it is retention, whether it is incontinence. The next step is, at least we should suspect quadra equina. So what is the next best step to do? Imaging. And what is the best imaging? MRI. Open fracture contamination, always IV antibiotic and tetanus. Obviously, we don't do it unless we ask the patient first to find out if the patient is a good candidate for the tetanus shot. Limb ischemia after injury. Obviously, if we see somebody had an injury after a trauma, now the patient has sign and symptom of ischemia, what should we do? Let's say the patient has a joint dislocation. After joint dislocation, the sign and symptom of ischemia is present, so reduction and reassessment. So we check the pulse, we check all the sign and symptom of ischemia to make sure they are present, and then we do reduce, and then we recheck and we reassess that did this reduction help? If not, then we have to escalate the management. MCQ on pattern, identify the unstable or limb-threatening condition first, then choose the immediate management step before definitive details. Universal emergency department approach to orthopedic emergency. Obviously, it will always be any emergency case will be started with A, B, C, D, E, and then analgesia, expose the limb, neurovascular examination, immobilize if it is dislocated, reduce it, imaging, consult, and operation room. Always document if the patient has pulse abnormality, whether it is pulse dorsalis, pulse tibialis, or radial or ulnar, you need to document it. Capillary refill and temperature, motor function, sensory territories, and before and after reduction casting. So what should we not do? All right, so I don't think it is mine. It's probably from your side, or probably it is your internet. I hope nobody else has the same issue. So if you guys have issue with my voice, raise your hand. All right, so do not delay. Good, thank you very much. So if there is any abnormality when it comes to checking the pulse, if you don't feel the pulse and the patient has pain out of proportion and the pain worsen with a passive stretch, please do fasciotomy for compartment syndrome. Atherosynthesis, as I mentioned before, for the joint, which is hot and swelling. If there is a capillary refill and temperature difference, obviously, if you see the sign of ischemia after any dislocation, do a reduction for ischemic fracture and dislocation. IV antibiotic if it is open, and MRI for the cauda eguana. So these are the things that if you know, probably you get 1-2 questions out of these, or probably more than that. So you know what to choose. So the exam wording, probably when they give you the scenario, they will be asking you, what is the best next step, most appropriate management, initial diagnostic test, most concerning findings, and do not miss. So I doubt it if they ask you do not miss, but the first 4 will definitely be part of the scenarios. Orthopedic emergency, this is something that you have to memorize it, unfortunately. So this is a mnemonic that is very popular in Canada, and I'm not sure if other countries are using it as well, but it is very popular in Canada. If you work in emergency department, this is something that you have to memorize and you have to know it. A fast way to prioritize limb-threatening and life-threatening diagnosis. So Von Chop. What is Von Chop? Von Chop is a vascular compromises. If you see anything that is compromised, any patient with a compromised vascular compromise, then it means the exam consequences will be ischemia, limb loss, urgent reduction, or vascular consult. So open fracture, we need to think about infection, tetanus, urgent antibiotic, and debridement. And for neurological compromise, cauda eguana, nerve palsy, and permanent deficit. C, compartment syndrome, muscle nerve necrosis within hours. So why it is important? Because if you delay, you will cost somebody a limb or you will cost somebody a life. So that's why you have to go through all of them in an orderly fashion, like Von Chop, V for vascular compromise, O for the open fracture, N for neurological compromise, C for the compartment syndrome, and H for the hip dislocation or major dislocation, hip major dislocation. So O for osteoarthritis or septic arthritis, P for pelvic fracture, especially if it is unstable. And the exam consequences, so what we should be expecting or what is going to happen if we delay. So obviously costing somebody a limb or a life. Septic arthritis. So the core vignettes clues. in a septic arthritis, I think everybody knows that it's going to be a monoarthritis, right? So the clue, if they gave you in the scenario, they will mention acute monoarthritis. One of the joint will be affected. It will be warm, it's an clue, erythematosis, and swollen joint. Severe pain with a passive range of motion is almost the same thing like a compartment syndrome. You have pain out of proportion with a passive stretching, or this one is the same thing. You have pain, and also not only you have a pain, you have severe pain with a passive range of motion. Fever may be present, may not be present. So do not be fooled by absence of fever or a mild fever. Because when we hear septic arthritis, what do we expect from the clinical vignettes? To have high fever. But if they don't mention, which usually they will trick you with this, they mention mild fever, or they mention the patient has no fever. So if you see no fever, do not be fooled by it. So if you have a monoarthritis, the clinical picture is there. So still you have to do more investigation to confirm the diagnosis. It means you still have to be suspicious about septic arthritis. If the patient clinical picture is matching what you think or suspect. And the reason that they mentioned that why fever might not be present, for example, septic arthritis can happen to anyone, but elderlies, someone with a diabetes mellitus, somebody with other comorbidity condition, or someone with a rheumatoid arthritis, they're already taking some medication that will cover the pain and the fever. For example, somebody who has rheumatoid arthritis, septic arthritis could happen as a consequence or complication of rheumatoid arthritis. So the patient is already taking a steroid, already taking the non-steroidal anti-inflammatory drug, but the pain could be there, but the fever might be mild or might not even show. And the fever, also the same thing with the diabetes mellitus. Why? The patient with diabetes mellitus has a lot of other comorbidities that they are taking Tylenol, aspirin, steroid, and also non-steroidal anti-inflammatory drug. On top of that, they might even take the opiates as well. So it's very hard to find the fever in elderly. But in young patients that they are not taking any other immunosuppressant medication, non-steroidal anti-inflammatory drug, it will be high. Okay. Inability to bear weight is another clue. All right. So usually for the inability to bear weight, they might give you a scenario about children. For example, let's say 14 years old, has hip pain on one side, cannot walk or refuse to walk. This one is septic arthritis until proven otherwise. Okay, so inability to bear weight could be one of the significant findings. So pay attention, keep it in mind. High risk patient. So out of these risk patients, if you notice, I only made elderly, diabetes, and skin infection or IV drug user red. So it doesn't mean that the rest of them are not important risk factors. They are. But most commonly, risk that they use in a clinical vignettes is elderly, diabetic patient, and someone with a IV drug use history or a skin infection. I have seen also rheumatoid arthritis. I have seen the prosthetic joint and also recent surgery injection, but not as commonly as elderly, diabetic, and a skin infection. Okay, so these are the risk factors. If they give you a scenario, these are one of them will definitely be part of the clinical vignettes to make it more specific to septic arthritis. Most commonly affected joints in adult exam, if they give you an adult with a septic arthritis, they will give you knee. But if they give you children or pediatric, they will give you hip. Okay, so remember, I gave you an example before. For example, you have 14 years old, hip pain, refusing to walk. It is septic arthritis until proven otherwise. Why? Because hip is more common joint to have septic arthritis in pediatric population, but in adult and elderly population, usually they give you the joint, the knee joint for the septic arthritis. Okay, moving on. Septic arthritis diagnostic priorities. So these are the things that we need to do when it comes to investigation. So if you're doing MCQ1 or if you're preparing for the MCQ1, they will usually ask you what is the next step. So they give you a clear picture or characteristic picture of a septic arthritis, and they will ask you what is the next step. Obviously, we have to confirm it. And the next step, one of these will be part of the options, right? For example, they might give you CT scan, they might give you MRI, they might give you ultrasound, and they might give you just, for example, blood culture plus, for example, synovial gram stain culture, this and that. One of them will be part of it. Then you obviously go with this, right? But if you're doing a NACOSCI, you might get these as a post-encounter question. For example, you dealt with your station, which was a septic arthritis. Now they will ask you what is your next step as a part of management. Which steps are you taking to confirm that this is a septic arthritis? Now you have to mention all this: synovial gram stain, culture. Why? Then you have to justify. If you do anything for the NACOSCI, whatever you do, you need to justify. If you do that, why? What are the reasons? You need to support what you're saying. For example, I do this to identify the organism. Required before narrowing, antibiotic. Synovial WBC and neutrophil. Why do I have to do it? Shows inflammatory burden. And if it is more than 50,000 cells and more than 90% neutrophils. That is specific, right? Crystal analysis to check or rule out gout arthritis or pseudogout. Blood culture to detect bacteremia, obtained with this, when septic arthritis suspected. So ESR, CRP, and CBC, supported and trend. They're not key diagnostic, but we are using it as supportive. X-ray rules out mimics, things that they mimic the same condition, can be normal early. Dangerous trap, treating gout with non-steroid or steroid before excluding infection in a hot monoarticular joint. What it means that we know that the patient might come with one joint pain, exactly the same presentation like septic arthritis. One joint might be inflamed, might be painful, and the patient might be elderly, patient might be adult with a diabetic or something that also matches the clinical picture of the septic arthritis. So it doesn't mean that every monoarthritis is gout. So it means before you starting to treat it as a gout, you need to do investigation to rule out septic, because for us, monoarthritis is septic arthritis until proven otherwise. So we don't start non-steroid anti-inflammatory drug to treat the gout, which we don't even know if it is the one, or a steroid, okay? This is a dangerous trap because one of the options might be, since it's a gout arthritis, I start treating with a non-steroid, and that will be the wrong option. Septic arthritis management sequences. So if you're suspecting, aspirate. When you aspirate, start the IV antibiotic. Let's say IV antibiotic does not help, or if it is huge, then you have to drain the joint or reassess. So start after aspiration antibiotic. When we do it after aspiration, if the patient is stable. We never do this if the patient is not stable. So we have to stabilize the patient first, then we do that, because it's all emergency, right? So cover like organism, likely organism and patient risk, adjust to culture and sensitivity, gonococcal risk, things of Jackson. So again, so when it comes to monoarthritis, these things should be ruled out. Again, you might get as a post-encounter question in NACOSCI, or you might get this as part of one of the option, like multiple choice option. So gonococcal risk is high when you have a young, sexually active patient who recently had unprotected sex with somebody that was suspicious to have STD. If the patient had STD and your patient had an unprotected sex with someone who was suspected to have STD, and now the patient developed a monoarthritis, which is jumping from joint to joint, that is probably a gonococcal arthritis. But we still have to do the investigation. Aspirate the joint. So drainage, serial aspiration may be needed, arthroscopy or open drainage if persistent. So what we do when we aspirate, we start the antibiotic. Remember, for any infection, when you treat any infection, the patient has to improve with antibiotic, especially if it is IV, because it's going to be a high dose. With an IV antibiotic, the patient has to start improving within 24 to 72 hours. 24 to 48 hours, maximum is 72 hours. Any infection, regardless of joint, lung, kidneys, anywhere in your body, if the patient is in the hospital, you start IV antibiotic, the patient has to start improving. The symptom has to start improving within 24 to 48, maximum 72 hours. So if your patient is not improving within 24 hours, it means either the antibiotic is not maximum dose, or there are some supportive treatment that has to be done to help the antibiotic to fight. For example, in this case, if you have a septic arthritis, if you start the IV antibiotic, but the patient is not improving within 24 hours, then you start draining. So it means the amount of the affected fluid is so much that antibiotic by itself cannot control it. So you have to drain to help the antibiotic to overcome. Now, within 24 hours to 48 hours, if it is not improving, again, if there is more fluid to be drained, you drain. If it is not, then you have to consider to add more antibiotic or increase the dose if it is not max. But if somebody is not improving within 72 hours, it means that you have to reconsider your diagnosis. It doesn't mean that it might not be the diagnosis. It means that either this medication that you're using is not sensitive to that organism, it's not working, so the patient has resistance to that specific antibiotic or combination, or it is completely a different diagnosis. So that is the cutoff, the 72 hours. But within this 72 hours, the patient has to start improving. If not, the supportive management has to come in. So persistent fever effusion, poor source control, as I mentioned before. So rapid cartilage destruction, bacteremia and sepsis, chronic pain and stiffness, permanent function loss. These could be part of the complications. Septic arthritis, I think I did mention all this, but this is a different way of approaching it. Just mentioned the medication, cefazolin, vancomycin, alternative, and also ceftriaxone for gram negative. Compartment syndrome. So compartment syndrome, high yield clues. If they give you a clue, what are those clues? The 5P, right? The 5P. What is the first P? Pain. This is the most sensitive and the earliest finding in compartment syndrome. And it is very characteristic finding. The pain is out of proportion. The pain is not responding to analgesic. It increased by passive stretch, right? So it is pain. The second P is pallor. But remember, pallor may happen very late. Pulse may not be present. Again, same like pallor, it might happen very late. Paralyzed, again, not early symptom, not early finding. It may happen very late. Paresthesia might be happening after pain or might happen before paralysis. But the most important question that you might get for compartment syndrome, what is the earliest finding? The earliest finding would be pain out of proportion. Not only pain out of proportion, the pain that's not responding to analgesic, the pain that is worsened by the passive stretching. So you may get a case that the patient has pain, the patient meets all the criteria for compartment syndrome. For example, the patient is working in the office. She's constantly typing. And the patient is obese. The patient has hypothyroidism. The patient is also pregnant. So she has all these risk factors, right? And the patient has pain. The pain is out of proportion. The pain is not responding to analgesic. The pain is worsening with a passive stretching. But the pulse is there. So pulse, presence of pulse or absence of pulse does not rule in or rule out compartment syndrome. Do not get fooled by presence or absence of pulse. When the pulse is absent or paralysis is present, it means the damage has been already done. It is very late stage. Okay, so pulseless is the late stage of the compartment syndrome. It is not present in the early stage. Pallor is the same thing. So it is not only in the wrist, it can happen in tibia, in the ankle. Tibia shaft fracture could cause it. Forearm fracture can cause it. Crash injury can cause it. Perfusion injury and tight casting. This one, I have seen it in some subscription, more commonly tested, that the patient is using cast, very tight cast. After a few hours of that cast, the patient develops pain and paresthesia. So the first thing that comes to your mind after somebody put the cast on and develop pain and also pallor or paresthesia, then think about compartment syndrome. Pulse can remain present until late stage, as I mentioned before. A palpable pulse does not rule out compartment syndrome. So compartment syndrome diagnosis and action. So awake patient plus classic sign and symptom. If your patient is stable, if your patient is awake, the patient comes to you, what do? Urgent fasciotomy. That's the treatment, right? Do not wait for pulse to be lost, because if the pulse is gone, then the damage has been already done. Tight cast plus worsening pain, the first thing you need to do is remove the cast immediately. That will be your next step, okay? That will be your next step. You might get a case that someone who had a broken, for example, tibia or fibula, and the patient put a tight cast, and after a few hours, the patient developed pain and worsening pain. So what is the next step? The next step for this patient is to remove the trigger. What caused it? The cause is the cast. Remove it. Do not only prescribe analgesic. It's okay, it's just for the cast. Take this one, sleep it off, you will be fine. No, the patient will lose the limb. Okay? Cast, after cast, the patient develops pain, remove it. Unconscious, sedated, or intoxicated. Okay, now we have two different scenarios. One scenario, the patient comes to you. The patient is conscious, the patient is awake, and the patient comes to you with a characteristic find of compartment syndrome. So it's a clinical diagnosis, right? So the patient has to give you a clear-cut picture of the compartment syndrome. Then you would be in a better position to say, yes, it is compartment syndrome, so I'm going to do a fasciotomy. But what if the patient was under rebels? There's a heavy machine on top of his hand or lower limb. Now the patient is in the emergency department. He's unconscious. I cannot ask him if he has pain. In that case, pain is not there. Why? Because the patient is unconscious. He can't even tell you if there is a pain, right? So if you guys remember in the last slide, I mentioned the most important or the earliest finding is the pain. Now we don't have it. The rest of them is not sensitive enough to help us to diagnose the compartment syndrome. Now, what should we do? Now, since the patient cannot give us a good clinical picture of or give us a good history, now I have to do a pressure measurement. Okay, for unconscious, sedated, intoxicated, if you're suspecting this might be a compartment syndrome, the pain might be absent. So that is not now the most sensitive finding or clinical finding for us to help us with the diagnosis. For me, now I have to go check for the pressure, compartment pressure monitoring. If it is above 30, then that is compartment syndrome. Elevated pressure or high suspicious surgical decompression. Obviously, we do that. Post-fasciotomy care, debridement, and delayed closure if needed. So if there is an cut and there is constriction, we never close it until we are 100% sure that it doesn't cause compartment syndrome. Now, for the complication or what happens if we delay. So Volkmann contraction, fixed flexion deformity after ischemia, permanent fibrosis after muscle necrosis, rhabdomyolysis, dark urine. So the characteristic finding would be dark urine, high creatinine kinase, hyperkalemia, myoglobin can cause acute kidney injuries. Nerve necrosis, persistent sensory motor deficit may become irreversible. Renal failure, rising creatinine after crash injury. Needs fluid and electrolyte monitoring. Limb loss, late ischemia and necrosis. Delay in fasciotomy increase the risk. So MCQ1 clue, crash injury plus delayed treatment and plus dark urine and high creatinine kinase is equal to rhabdomyolysis, which they might test you on complication rather than diagnose, okay, when it comes to compartment syndrome. And this is the Volkmann contraction. This is how it looks. The elbow will be flexed, the forearm will be pronated, the wrist will be flexed, the metaphalangeal extension, intraphalangeal flexion, thumb adduction, and this is how it is. And sometimes it also happens as a result of tight cast, not removed on time. Cauda iguana syndrome, very commonly tested. It is also one of the orthopedic emergency. Must not miss clue. So the clues that you cannot miss is urinary retention, subtle anesthesia, reduced anal tone, bilateral sciatica or weakness, bowel and sexual dysfunction. So if you're doing an arthroscopy, let's say you have a patient with a back pain, if you do not rule out or exclude Cauda equina, you will definitely fail that station, because this is something that is their priority, especially if the patient is in emergency, because the setting also matters. And trust me, 100% you get one back pain. Very important. That's why when usually IMGs who wants to do their licensing exam and they're preparing for MCQ1, I always encourage them to do the MCQ1 and NACOSC at the same time. Why? Because the topics are the same. Like back pain is as important as a topic that this is the important topic that comes also in MCQ1 and also it comes in an NACOSC. The topics are the same, but the approach will be different. For example, in Cauda iguana, in MCQ1, they probably give you a scenario about someone who has a back pain, and then they will ask you, what will be your next step to ask? Obviously, you have to ask about the clues that rules out the Cauda iguana. Ask if the patient has urinary retention. right? So, or saddle anesthesia, one of them will be in the option. One of them will be in the option. So you need to know that that is emergency. I have to rule it out first. If it is not that, then I'm okay. Then I can take my time and take the history. But if you're doing a narcolepsy station, you have to ask every single one of them to make sure that the patient does not have cauda iguana, because you're wasting your time if the patient has cauda iguana and you're just sitting, running investigation, running blood work, discharging the patient, doing the follow-up, asking the patient to take the painkiller. So you're wasting your time. So immediately you have to do an MRI and you have to refer the patient for the surgery, right? So basically the topics in MCQ and NACOSC are the same, and just the approach might be different. For example, as I give you an example, they're asking you what is your best next step, but in NACOSC, they might ask you, just go and do a consultation for this patient. What is the problem with him? What is cauda iguana? So if you're consulting on cauda iguana, you need to know cauda iguana inside out. From A to Z, you have to know everything. Why? Because in consultation, you're educating your patient that what is the problem or what is the issue that he has, and what are your next step to solve this issue, and what are the chances of the patient to get better, and what is the next step, when is the next follow-up, and what else does she have to do during that time. So now, if you study the cauda iguana with that details for the NACOSC, do you think you miss anything in MCQ? And no. So that's why I always encourage the Angie, do MCQ and NACOSC at the same time, because no matter what you're doing, the topics in MCQ and NACOSC are the same thing. Whether you're studying for MCQ1 or NACOSC, you are improving every day. But anyway, let's get back to the point. Urinary retention, you cannot forget about the back pain. Any back pain, regardless of the age, you have to ask this question. Do you have any problem with your any recent issue with the bowel movement, any recent issue with the bladder movement? So you have to ask these questions if you're taking history and NACOSC. And in MCQ1, look, if somebody comes with a back pain, look for these clues. Look for the urinary retention, look for the saddle anesthesia, look for the reduced anal tone, and look for the bilateral sciatica or weakness, and bowel or sexual dysfunction. If it is present, it is emergency. Go for the option that is for emergency. MRI, surgery. That's it. Don't even think about the X-ray, ultrasound, painkiller, this and that. Forget about them. X-ray. Forget about it. Two things: MRI, surgery. Common cause: large center herniation, tumor or metastasis, epidural abscess, epidural hematoma, and trauma. These will be common causes. So obviously they give you somebody with a back pain who had, for example, epidural abscess, or they might not even mention that. They might indirectly mention the patient is a IV drug user, or they might mention that the patient had recent trauma, or the patient had a fall. So they mention somehow, directly or indirectly, the trigger or the cause. Urinary retention is usually more concerning than the vague urinary frequency in the back pain. Remember that the cauda iguana could have incontinence, or the patient may have urinary incontinence as opposed to urinary retention. But most common is urinary retention. Any back pain with any abnormality in bladder dysfunction, bladder dysfunction, is cauda iguana until proven otherwise. Let's put it that way. Cauda iguana emergency pathway: saddle anesthesia, so sacral sensory route involvement, urinary retention, urological bladder until proven otherwise, bilateral, decreased anal tone. So we did discuss this. I'm going to move on to the next slide. Back pain, routine radiculopathy versus cauda iguana. All right, so I think I have a better picture to show you guys. Yeah, this slide is much better. So routine radiculopathy or cauda iguana. So it is usually unilateral when it comes to radiculopathy or sciatica. It doesn't mean it's not going to be bilateral, but usually it is unilateral. But cauda iguana is usually bilateral. So a straight leg test might be, will be positive in sciatica. Straight leg may be positive in cauda iguana. Bladder bowel movement, both of them will be normal in sciatica, but it will be abnormal in cauda iguana. Saddle anesthesia is not present in radiculopathy. If it is present, it is cauda iguana. Motor sensory absent or mild, but in this case, it will be more progressive. Weakness is more progressive. The initial management is conservative. For this one, just physiotherapy, exercise, this and that, and the patient will get better. But for this one, MRI plus surgical assessment. Good. The exam trap, a positive straight leg test alone is not cauda iguana. Bladder dysfunction and saddle anesthesia changed the answer. Out of all these findings, back pain with bladder dysfunction and saddle anesthesia is very characteristic finding of cauda iguana. So cauda iguana, usually this actually could be a question that where does it usually happen? Below the conus medullaris. Please remember this because I have seen it in many subscriptions as a quiz, as a test, okay? Remember, conus medullaris. So you have this picture in your notes. If you're JAWL Academy member, you have it part of the orthopedic notes. We just updated the whole notes and you should be able to access it. Maybe the next question might be, this is not one of the options that you're looking under conus medullaris. Maybe you have another option, which is L4, L5, or maybe any other levels. But most common level is L4, L5. It can happen anywhere less than L2. Less than L2, up to S2, S1, sorry. Less than L2 up to S1, it can happen anywhere. But the most common area that it can happen is between L4 and L5. Open fracture emergency management. Immediate steps. Obviously, for any fracture or orthopedic surgery, what do we do? ABCDE. And resuscitation. Cover with a trial dressing, immediate IV antibiotic, tetanus assessment, NPU, plus urgent orthopedics. So avoid. What should we avoid? Do not close an emergency department. Do not repeatedly probe the wound. Do not delay antibiotic or operation room. Do not miss small puncture wound. So even if you have a small puncture, but the wound is communicating with this bone, if you see the bone, that is called open fracture. A small wound over the fracture may still be an open fracture if it is communicating with the fracture hematoma. Open fracture classification, Castillo, simplified. Just to make it very simple, less than 1 centimeter is 1, 1 to 10 is 2, more than 10 is 3A. If it is extensive and the bone is exposed, it is 3B. If vascular injury is present, then it is 3C. Less than 1 centimeter is 1. 1 to 10 is 2. Above 10 centimeter is considered 3A. If the bone has if it starts to communicate with the bone, or if you see the bone, then it is 3B. But if the vascular compromise is present, then it is 3C. And IV sulfonylurea up to here, and then add gram-negative coverage. And obviously, for the vascular injury, we have to do the vascular orthopedic management as well. And for the, if tissue is lost, then we have to do the flap and soft tissue plan. So this is the same thing and showing you the pictures with it. So almost the same thing. Open fracture and tetanus, OR, and damage control. Okay. Assess the wound risk and vaccine history. Dirty wound. So dirty wound booster if more than 5. If it is clean, more than 10. Two different things. Okay. So for any incomplete unknown series immunoglobulin, we use if it is dirty immunoglobulin. If it is clean, we don't have to. So two things to remember. Is it clean? Is it dirty? I think I have a slide. Where is slide? Okay, we are here. This is Toronto note. Yeah, this is mine. I think mine is a little bit short, concise. It's better. So when it comes to wound and tetanus, two things to pay attention. Is it dirty or it's clean? If it is clean, the next question I should ask is, has the patient received all the 3 doses of tetanus? If the patient has received it, was the last one more than 10 years? Because it's clean, 10 years, okay? Because it is clean, 10 years. If the patient has received it less than 10 years, then in that case, we don't need any vaccination. If the patient has received it more than 10 years, then the patient is not immune. So the patient has to receive a boosting dose. Now for dirty, same thing. The next question, have you received it? The patient says yes. When was the last dose? The last dose was less than 5 years or more than. Since it's dirty, we shorten the duration. For the clean, 10 years. For the dirty, 5 years. Okay? So if the patient says, yes, I got it like 3 years ago, no vaccination. If this patient says 15 years ago, and it's dirty, obviously, he has to receive the vaccination. And this is the Toronto note. It's a little bit, maybe I should add here Toronto note. All right. So this is from Toronto Notes. It's a little bit longer. It has more information. I tried to make it a little bit concise, but it's totally up to you which one you prefer to study. This is Toronto Note. This is mine. And this is also mine. So basically the same thing. I'm not going to waste your time on this one. Neurovascular compromise, the required exam. So the domain, vascular, PAS, capillary fill, contour, temperature, Doppler, ankle brachial index. So high yield examples, popliteal artery after knee dislocation, brachial artery after elbow injury. So what does this slide mean? Like you might get a case that the patient had a knee dislocation. Regardless of the knee repositioning or reduction, whether it happened manually or by itself or by a doctor, we have to check for the popliteal artery because that is the artery which is at high risk of damaging or getting damaged by the dislocation. Okay? So any knee dislocation before and after reduction, we have to check for popliteal artery. So this is what they expect you to know, and it will be in the exam. So you cannot forget it. And if it is brachial artery after elbow injury, for the elbow injury, the same thing. We discussed for the knee, the same thing. If you have an elbow dislocation, you need to check for the brachial artery before and after dislocation. Why? Because they are going to be compromised. When the dislocation happens, they will get compromised. For the motor nerve, usually get nerve action. So you have to name that. You need to know like in which location or in which part, which nerve is going to get damaged. For example, radial nerve is used for wrist extension. So if the patient cannot extend the wrist, it means the radial nerve has been affected. Medialis, usually the thumb opposition, the thumb opposition. So if the patient has had a trauma or a fracture or any dislocation in any joint and the patient cannot do the opposition thumb opposition, it means the median nerve has been affected. So you need to name it. Or it as a part of the MCQ1. In Nakoski, the patient can do that in a physical examination. Once you're done, the examiner will ask you. So the patient mentioned that he cannot do wrist extension, or the patient could not do the thumb opposition, or the patient could not spread the finger. What do you think? Which nerve is involved or affected? So you should be able to tell that, for example, for a wrist extension, it will be the radial. For the finger, spreading finger, it is ulnar nerve. And for the thumb opposition, it is medial nerve. Now, sensory, auxiliary, deltoid patch, this area. So auxiliary patch, usually in the lateral area of the deltoid, the patient might have lost the sensation. So in terms of sensation, auxiliary nerve is the one that you have to be able to name it. Median, thumb, index, and middle, which I did mention it for you guys. I think I have a picture of it. So the medial side of the palm up to half of the ring finger. And radial is the dorsal area or back of the hand. So basically, if they give you a scenario about a fracture or dislocation, if they mention the dorsal area, think about the radial. If they mention the medial area, it's obviously the palm is the medial nerve. For the compartment syndrome, usually it is medial nerve, and documentation before and after intervention, protect patient safety, and exam answer logically. If pulse, temperature, motor function, or sensation worsen after reduction or splinting, reassess immediately and escalate. So as I mentioned before, that before we do any reduction, we have to check for the pulse, temperature, sensation, and also for the power. And then after that, also we check for all that. And the patient should be good. If it doesn't return, it means ischemia has happened. What should I do? I have to involve the surgeon, vascular surgeon. Okay? Neurovascular compromise, classic MCQ1 scenario. So now they're going to give you a scenario. Let's say the first scenario is a patient with anterior shoulder dislocation. So anterior shoulder dislocation and deltoid patch numbness. See, before we just talked, deltoid patch numbness. So if the patient has deltoid patch numbness, which nerve is going to be affected? Axillary nerve. This is what they expect you to know. And knee dislocation, even reduced plus cold feet, you have to check for the popliteal arteries. And sorry, this is what they expect you to know. An ankle fracture, dislocation, absent pass, vascular compression, urgent reduction. Radial, distal radius fracture, median nerve. Yeah. And acute carpal tunnel syndrome. Loosen assessment, decompress if needed, humeral fracture, plus wrist drop. So humeral fracture and wrist drop. So it means the patient cannot extend the wrist. So which nerve is affected? Radial nerve. So humeral fracture, radial nerve. Wrist drop, radial nerve. Exam rule, deformity causing ischemia should be reduced urgently. Then neurovascular status must be reassessed. So this is a beautiful picture or slide. Again, you have it in your notes. Deltoid patch, radial nerve, which is used for the wrist extension, popliteal artery, brachial artery for the elbow dislocation, ulnar nerve for spreading finger, radial nerve for the dorsal hand, medial nerve for the compartment syndrome. Compartment syndrome is here again. and the 5 Ps. All right, fracture dislocation with ischemia, reduction logic. So if you have fracture dislocation with ischemia, the first thing you need to do is reduce. Why? Because the reason for ischemia is the dislocation, right? So assess neurovascular status, analgesic, reduce the deformity. So we have to assess if the patient has no pulse, obviously it is affected. So we need to sedate the patient, or we have to provide them with a painkiller in order to be able to reduce the dislocation. So the patient is sedated, or the patient is having enough painkiller. He is ready for the reduction. We do the reduction. And then once we are done, since we already checked the temperature, the pulse, and everything, the color, now we are going to recheck all that to make sure that the reduction actually helped. The ischemia hasn't happened. If the reduction is done, but still the patient has all those ischemic symptoms, it means I have to involve the surgeon. Okay. Heart vascular sign, absent pulse, cool pale limb, expanding hematoma, bruised trail, active arterial bleeding. After reduction, pulse restored, capillary flow improved, sensation motor improved, spleen safety, urgent vascular consultation if abnormal. Do not miss, knee dislocation may reduce spontaneously. So even if it is reduced by itself, it doesn't mean that I don't have to check for the popliteal artery. I have to check. For the elbow brachial artery, I have to check. Okay, regardless, we have to check it, even if it is reduced on its own. Popliteal artery injury can be occult, ABI or ankylobrachial index, CT angio if concerned. Delayed diagnosis can be caused amputation. So we shouldn't delay. As I mentioned before, the orthopedic emergency, the reason for that is to recognize it early and save life and limb. Not only life, the limb as well. All right, imaging rules in these emergency. So presentation, if it is hot swelling, ultracentesis first, X-ray only if there is a mimic, things that mimics it. Exam trap, do not wait for imaging to aspirate. Okay. Compartment syndrome, clinical diagnosis. It is clinical diagnosis. Do not delay the fasciotomy for MRI CT scan. We don't do that. We do the fasciotomy. Unconscious with a tense compartment. Since the patient cannot talk, I cannot get a good history because it is clinical diagnosis. I have to do the pressure monitoring or measurement. Pain cannot be assessed. Cauda iguana red flag if the patient has urinary retention, subtle anesthesia, bladder dysfunction, bowel dysfunction, or the pain and weakness in both sides, and it's progressive, then I have to do the MRI and decompression. Plain X-ray is not adequate. We don't waste our time on that. Open fracture, X-ray after ABC, antibiotic, include joint above and below. Do not delay the IV antibiotic for imaging. Vascular compromise, reduction first. If there's a vascular compromise which happened after dislocation. The first thing that we need to do, check for obviously the vascular is compromised, so we have to do the reduction. Once we do the reduction, we check for the same thing again, like is the vascular function is back or not. CT angiography, vascular consult if abnormal. Pulse must be reassessed. Now, MCQ1 answer strategy for orthopedic surgery. So identify the threat. Joint distraction, muscle nerve necrosis, bladder, sexual dysfunction, osteomyelitis, tetanus sepsis, limb ischemia. Selection action. Should I do aspiration, joint distraction, muscle nerve necrosis, fasciotomy or release cast, bladder and sexual dysfunction, urgent MRI, osteomyelitis, tetanus sepsis. For osteomyelitis and sepsis, IV antibiotic and tetanus. Limb ischemia, reduce or vascular consult. reject distractor, outpatient referral, we can discharge the patient with a joint which is swollen and hot, and it's monoarthritis, right? It is septic arthritis until proven otherwise. They cannot treat this patient as an outpatient. The patient should be inpatient so that they can run some investigation at the same time and have to start the IV antibiotic. So muscle nerve necrosis, I have to do fasciotomy. I cannot delay it for routine X-ray. Bladder or sexual dysfunction, straight before infection, or osteomyelitis, IV antibiotic, tetanus, analgesic only answer. I can do that. Limb ischemia, reduce, or vascular consult, waiting for the late sign. We never wait for the late sign, because if it is late, it is already late, right? So the damage will be already done. In the exam, the correct option is often the one that prevents irreversible harm within hours, because it's emergency. The time is essential. One slide emergency matrix. So septic arthritis, it will be hot, swollen joint, passive range of motion pain. This is what we do. We do the arthrocentesis and then IV antibiotic. So we aspirate, IV antibiotic, and drainage. Compartment, pain out of proportion, passive stretch, remove the constriction if it is caused by the cast or tight casting. So we remove it. Urgent fasciotomy. Cauda equina, urinary retention, subtle anesthesia. We do urgent MRI and decompression. Open fracture, one communication. One communicates with the fracture. So if it is one communicating with the bone, it is considered as an open fracture. IV antibiotic, tetanus, and sterile dressing, and OR. Neurovascular compromise, like cold, pale, limp, weak, past, nerve deficit, urgent reduction, or vascular assessment. This table is the safest last-minute version slide for this lecture. So this is very important. Please take a screenshot if you want to, because it's very important. It helps you a lot with your exam. Now, debriefing, MCQ debriefing, septic arthritis. So elderly, febrile, hot knee, passive range of motion pain. This is what we do. Child refuses to walk with a febrile, painful hip. I think I did mention this at the beginning of this lecture, that it is septic arthritis until proven otherwise, right? Usually the joint that is going to be affected by septic arthritis is hip for the pediatric population, but knee for the adults, right? So rheumatoid arthritis, a straight patient with acute wrist monoarthritis. So any monoarthritis is septic arthritis until proven otherwise. So septic arthritis is usually in the knee, but it doesn't mean it cannot be in the wrist. But remember, gonococcal is usually in the wrist, in the fingers, and in the ankles. But again, I have to rule out septic arthritis. Then gonococcal, then gout. So the specific joints for a specific arthritis is different. For example, for gout, it is usually big toe, but it is not always like that. Usually it is that, but sometimes it could happen in the ankle, it could happen in the finger, it could happen in the wrist. But mostly, if they want to test you on gout, they give you a big toe, okay? For the gonococcal arthritis, usually they might give you wrist, finger, or ankle. These three, very commonly affected by the gonococcal, and they are migrating, okay? They are migrating. For the gonococcal, remember it is migrating arthritis. Now for septic arthritis, usually it is knee. Knee. For the adults, hip for the pediatric. So persistent fever, effusion after antibiotic, it means drain. Migrating arthralgia plus tenosynovitis plus sexual transmitting infection risk, like unprotected sex, gonococcal arthritis, infection after culture. Common wrong answers: serum uric acid, intraarticular steroid, oral antibiotic, outpatient referral. So these are common wrong answers. it means that we do not treat all monoarthritis as a gout. We cannot start treating all monoarthritis as a gout until we rule out septic and gonococcal. Now for the compartment syndrome, tibial fracture. So you have a patient with a tibial fracture. The patient is already on opioid, with it's not helping, and the patient has passive stretching, has worse pain with the passive stretching. So tibial fracture, not responding to analgesic, opioid, and worsening with a passive stretch. What is it? Compartment syndrome. So what should I do? It's a clear-cut picture or clear characteristic picture of compartment syndrome, fasciotomy. It's a clinical diagnosis, right? Now, pain and numbness under the tight cast. It is compartment syndrome. Remove the cast. Unconscious crash injury, tense leg. Now pain doesn't play any role in diagnosing. I have to do the measurement, the compartment measurement, pressure measurement. Question asked most sensitive early sign. You may get a question. The patient is a pregnant woman. The patient is obese. The patient has pain in the wrist. And the question is asking you, what is the most sensitive early sign? Pain with a passive stretch, or pain out of proportion, pain not responding to analgesic, and worsening with a passive stretch. Delayed treatment, any of them will be the answer, okay? Because sometimes pain with passive stretch will be the only option. Then there will be fever. There will be like high ESR, high CRP, this and that. But this will be the answer. So delayed treatment, dark urine, high CK, and maybe high potassium. Rhabdomyolysis. Common wrong answers. CT angiography when classic, repeat X-ray more opioid, waiting for the absent pass. So these are the wrong answer. If you're going for the CT angiography, it has nothing to do with the compartment syndrome because it is nerve. Repeat X-ray, we don't do that. More opioids because the patient is not improving with the opioid. This is a characteristic finding. It is not going to help to increase the opioid dose and waiting for the pass to be disappeared. That is the worst thing that you can do as a healthcare provider. Cauda iguana cases, back pain, urinary retention, subdural anesthesia. What is it? Cauda iguana. What should I do? Urgent MRI. Bilateral sciatica, perennial numbness plus reduced tone. This is also, what is it? Cauda iguana. Cancer plus bladder difficulty, preanal sensory loss. Again, what is it? Cauda iguana. Urinary retention is the most concerning one. Out of all of them, the urinary retention is the most concerning one. MRI confirms central disc compression, urgent decompression. Unilateral sciatica, normal bladder, saddle and strength. So it is not cauda iguana. This is radiculopathy. This is sciatica. What do we do? Conservative treatment. Ask the patient to do certain specific exercise and physiotherapy. Common wrong answer. For cauda iguana, do a lumbar X-ray. It's not going to help you. It's wasting your time. Outpatient neurology, wrong. Physiotherapy, wrong. Oral prednisone, wrong. Urgent MRI for uncomplicated radiculopathy, wrong. Why? If it is uncomplicated, we never do the MRI or CT scan, right? We don't even do the X-ray if it is not complicated, if it's only strain. So these might be one of the options, some of the options. For example, you have a patient with a retention, subdural anesthesia. What is the best next step? A, MRI. B, X-ray. C, outpatient neurology. D, physiotherapy. E, oral prednisone. Obviously, the rest was the wrong answer. And the first one is, which is the urgent MRI, is the right answer. All right, so open fracture cases, visible bone or wound over fracture, immediate IV antibiotic. Any open fracture, IV antibiotic, and we have to assess for the tetanus. Dirty farm soil wound with a old booster, tetanus booster, immunoglobulin, if incomplete or unknown. High energy communicated large wound brought IV coverage. A small puncture communicating with a hematoma, and even if it is a small, it is considered as a open fracture because it could be part of the Castello level 1 or stage 1. Unstable, pulley trauma, and fracture. For this patient, we have to stabilize the patient. Damage control, external fixation. We just externally fixate the patient. We stabilize the patient until the patient is able enough to undergo a very intense and aggressive surgery. We never perform a surgery in a patient who is unconscious and unstable. We stabilize the patient, and once the patient is stable, we stabilize the patient and we take care of the fracture with external fixation, and we control the damage until the patient is strong enough to go through a very aggressive and intensive, probably 1-2 hour surgery. Neurovascular compromised cases. So shoulder dislocation dealt with patch numbness. Which nerve is affected? Axillary. These are the repetition because you have to memorize it and it helps you to refresh your mind. Keep this knee dislocation plus cool foot, weak pulse, urgent vascular assessment. Ankle fracture, dislocation, absent pulse. Obviously, we have to do the reduction first. Why? Because the pulse is gone because of this dislocation. We have to reduce the dislocation and check for the pulse. If the pulse is back, good. If it is not, then we have to involve the surgeon. Distal radius, thumb, index, middle tingling, acute carpal tunnel syndrome. Humeral shaft is what? Radial nerve. Why? Because humeral shaft will cause wrist drop. Common wrong answer, outpatient MRI, analgesic only, discharge, delayed casting, ignore spontaneous reduction. These are all wrong answers. Never choose them. Okay. In this case, they might be the right answer for that different scenarios. All right. Sorry, guys. All right. A steroid, we're talking about the MCQ1 traps. So these distractors repeatedly appear in the orthopedic emergency cases. So do not get fooled by these distractors. They will distract you, okay? A street injection in a hot joint. We never do that, right? It makes it worse. Aspirate it. Use IV antibiotic. Waiting for the pulse list. We never do that. Act on the pain and passive stretching for the compartment syndrome, right? Lumbar x-ray for bladder retention. We never do that. This is distracting, dangerous. We lose a lot of mark. Never, ever do that. Urgent MRI. Oral antibiotic for open fracture, inadequate early prophylaxis, immediate IV antibiotic. We don't do oral. Please don't get this one wrong. When you see the antibiotic, don't jump because sometimes before we read it very thoroughly, we choose it. Okay, as soon as we know this is the septic arthritis, yes, antibiotic, let's do this. But pay attention, oral is not the best choice. IV is the best choice. You usually prescribe it for 4 to 6 weeks. But for the first 1 to 2 weeks, it's going to be IV. Then it's going to be changed into or step down to oral antibiotic later on. But you started with IV, okay? So oral antibiotic for the open fracture. We don't do that. For the open fracture or the septic arthritis, we usually started with IV. Outpatient MRI after knee dislocation. Urgent vascular assessment. So analgesic only after ischemic deformity. It is going to be very dangerous to do that. Urgent reduction assessment. Exam reading management script. So now this is for you if you are doing Nagoski. Septic arthritis. So this is septic arthritis until proven otherwise. You take the history. at the end of the day, you have the septic arthritis, right? In your mind, this patient has septic arthritis. Why? The patient meets all the characteristic clinical finding of the septic arthritis. So for you to explain it, which is going to be part of your presentation in that station, septic arthritis, you need to justify why do you think it is septic arthritis. So my patient is an elderly, my patient has rheumatoid arthritis, my patient has red, swollen, hot, mono arthritis on the right knee. See, I'm giving all the clues that makes it septic arthritis for this patient. So my first best diagnose, or at this point, my diagnosis is septic arthritis because my patient is an elderly diabetic with a past history of rheumatoid arthritis or a chronic disease, or the patient is taking a steroid, or the patient is taking immunosuppressant, and the patient has monoarthritis on the right joint. It is red, it is hot, it is swollen, the patient has fever, and the patient has systemic symptoms, right? So based on these findings, you justified it. This is my diagnosis. My second differential diagnosis is rheumatoid arthritis, osteoarthritis, monoarthritis, like a gonococcal arthritis or gout arthritis, whatever, then you justify it. So this is why I think this is the second diagnose, or my differential diagnose. But because the patient is not having this symptom, I don't put it as a first differential diagnosis. Or because the patient does not have polyarthritis, that's why it is not considered to be rheumatoid arthritis. Because this patient is young or old, that's why it is not this condition. So you need to justify every single differential diagnosis that you put after the most likely diagnosis. So the reason you give all the reason why it is the best diagnosis, and then if you put, for example, gonococcal arthritis as a second, why? Because gonococcal arthritis could be also monoarthritis, but it is usually in the wrist, usually in the finger, and usually in the ankle. And the patient usually have a history of unprotected sex with someone who was suspicious to have a sexual transmitting infection recently, which in my patient, it is negative. My patient is 68 years old and he has never engaged in sex, especially unprotected sex, or he's not even sexually active. Or gout, for example, my third differential diagnosis is gout, because gout could be also one of the condition that present as a monoarthritis, but usually it presents in the toe as opposed to the knee. It could be also in the knee, but more likely to be in the toe. And also, it usually happens somebody who is alcoholic, somebody who is taking hydrochlorothiazide, usually it happens or flares up after, for example, taking too much protein or having a barbecue or having a party, and it happens. So based on these findings, it is not likely to be septic arthritis. So I put it as a third differential diagnosis. I hope it makes sense. So when you are explaining anything, you need to justify it. But if you are going to give the clues to the examiner, this is septic arthritis and to prove an otherwise. So maybe he will ask you, how do you prove it otherwise? Obviously, you tell him that I do the CBC, I do the aspiration, I do the drainage, or the check, for example, for the gram stain, this and that. You have to justify. I would urgently aspirate. So this is going to be my next step. So my patient has all these clinical findings. Based on these clinical findings, I think my patient has septic arthritis. So the next step, I will be doing an aspiration. And after that, I would start the IV antibiotic. If my patient is continuing to get worse, after 24 hours, I will start doing the drainage. If the patient is still getting worse after 72 hours, I will reconsider my diagnosis, right? Now, let's say you have another station. Your station is compartment syndrome, which is commonly tested in NACOSC and MCQ1, very common. So pain out of proportion and passive stretch pain are early, and my patient, my most likely diagnosis for this patient is compartment syndrome. I would remove, constrict, or call orthopedics. Why? You justify it because my patient had a broken tibia and the patient was on a tight cast, and after a few hours, he developed the pain and numbness, which makes it most likely a compartment syndrome. So my next option is to remove this cast to solve the symptom or improve the symptom. Definitive treatment, if it does not help, then I have to do the fasciotomy. Bladder dysfunction and subtle anesthesia. For the back pain, I think I did mention it before, so I'm not going to waste your time. I would obtain urgent MRI, confirm compression needs urgent decompression. Open fracture, I would do the ABCDE, then sterile dress, immediate IV antibiotic and tetanus assessment, urgent operative irrigation, debridement based on the Gastillo. Neurovascular compromise, document neurovascular status before and after reduction. Ischemia fracture, dislocation needs urgent reduction. Persistent abnormal perfusion needs vascular consult. Okay, so most sensitive early sign of compartment syndrome. What is your answer? Pain with passive stretch. So these are the question and these are the answer. Regardless of what is the scenario, the last part of the scenario might be this question, okay? Best initial diagnostic test for septic arthritis, arthrocentesis. Back pain, red flag, most concerning for cauda equina is urinary retention. Open fracture, immediate medication priority is IV antibiotic, not oral IV. Knee dislocation, vascular injury to exclude popliteal artery injury. Even if the dislocation has been reduced on its own spontaneously, still we have to check for the popliteal artery. Humeral shaft fracture nerve at risk is radial. Anterior shoulder dislocation, nerve at risk is axillary nerve. Distal radius fracture, plasmodium symptoms, acute carpal tunnel syndrome. Take-home message, hot joint aspiration, passive stretch pain, fasciotomy pathway, bladder, saddle symptoms, MRI, open fracture, IV antibiotic, tetanus, cold, pulseless limb, reduce vascular consult, and clinical mindset, treat time sensitivity harm first, be assessed after intervention, document neurovascular finding, do not be reassured by a normal early imaging. Do not wait for the late sign, because when you wait for the late sign, it will be too late to treat the patient. It means the damage has been already done and you cannot fix anything. Okay, this is the high yield MCQ and Pearl. Basically, it covers everything from septic arthritis to compartment to cauda equina, open fracture, neurovascular compromise, which we covered them all. Thank you very much. Let's stop it here. And now if you have any question, I'm at your